Speaking of CAR T, how do you decide between CAR T cell therapy and bispecific, trispecific antibodies for relapsed or refractory disease?
So it depends. I think it all depends on where the patient is residing. Do they have access to CAR T tertiary centers? So when you think about CAR T therapies, those are pretty much only performed at tertiary centers. So here in Chicago, you have limited options is where you can actually have CAR T therapies performed. Bispecifics is a little bit different. Even in our private practice, we're doing bispecific treatment. And so, you think about, can the patient tolerate it? Do they have access? Number two, can they actually be hospitalized and receive the treatment and be monitored? You think about rural communities; they don't really have that access. They don't have the capabilities of being monitored or being able um, to have good transportation to go back and forth to these facilities. And then you need to think about the capacity of the community specialists. Can they actually perform these newer, novel treatments?
And just kind of thinking about that and the presence of people in rural communities, for example, what are some of the workarounds or maybe areas of you know cooperation between institutions? What resources and options do people have when there are these better options, but they might not be resourced to implement them?
Yeah, so I think that is really having a bridge and being able to collaborate with these tertiary or academic facilities. For instance, my practice, we have a wonderful affiliation with Rush, where one of our practitioners, our oncologist, he goes out to Rush and he is right in the middle doing these stem cell transplants. And so it's been a phenomenal way to take care of the patients in the communities, still allow them to get access to some of the best care at some of the tertiary facilities, but still be able to come back home where they feel comfortable and feel that they got the best care.
Mm. So, when it comes to bone protection, how are advances in bone protection, infection prevention, and managing toxicities improving patient outcomes?
So those, changing and having a good bundle as far as infection supportive management, I think is the mainstay. We've seen that, many of the life debilitating um, events with multiple myeloma is not just the disease itself. It is the in organ damage. It is the kidney failure. It is the bone metastasis, the lytic lesions that could ultimately lead to someone developing paralysis. And so having your bisphosphonates, your Xgeva, your Zometas available, one has helped and shown to prevent some of these life sustaining events, but it also has been shown to treat the disease itself. Having a infection bundle has been great, not only in the stem cell transplant era, but also when we think about all of these novel treatments, such as the daratumumab, the bortezomib. They have side effects or increased infections in itself. You have your herpes zosters and things like that. So you definitely have to make sure you have something to protect the patients.